Good evening. It's 7:02, Saturday, 23rd of May 2020. We are from National Palace in Mexico City, and we're going to start with our daily briefing on the situation about the epidemic the pandemic caused by the new coronavirus SARS-CoV-2. We're going to open up with our technical report, and then we will have our Q&A. Deputy Secretary, if I may, good evening, everybody. We're going to start with our briefing number 85, and this is day 62 of our National Safe Distancing campaign. Let's take a look at the numbers. Here we see the international overview of the pandemic. 24% of the active pandemic around the world. Just as we've been seeing over the past weeks, over the past month, the Americas is concentrating the majority of active cases. However, the ratio of cases for the Americas has been around 51% in terms of the distribution across Latin American and American regions. Europe is keeping the same trend, keeping a downward trend. Now, here we can see figures for Mexico. 215,656 tested people, out of which 118,137 tested negative. However, 60,856 people were tested positive for COVID-19, and they are confirmed COVID-19 cases. This is the illness caused by the SARS-CoV-2. More than one-fifth is the active epidemic in Mexico, 14,153 active confirmed cases. Within the group of the confirmed cases, we have the unfortunate fatalities that up to date account for 7,179. This is the map per state of the cumulative burden of the disease. More than 80% of the states show more than 500 cumulative cases. Today, we have one more state to the ones showing the highest number of cases. Tabasco, the state of Mexico, Mexico City, Baja California were already part of this group, and we have one new member. 51.5 is the incidence rate per 100,000 inhabitants. Now we see here in descending order the states that have the heaviest burden of the disease. Tabasco is joining this top 5 of cases, and you see on the left-hand side the states with the fewer numbers. This is a map showing the confirmed cases. Here, less than 80% of the states show less than 500 cases. 80% of the entities have less than 500 cases. This is the active epidemic, and only one state is entering the maximum range of more than 3,000 cases. And 14,253 are the active confirmed cases. Here you can see again in descending order the distribution of the different states. The next slide shows the cumulative incidence rate of the active epidemic in Mexico, 11.1 per 100,000 inhabitants. This is distributed based on the size of the different states and their behaviors of transmission and dispersion of the virus. The darker shades of green are states showing more transmission. Therefore, those are the entities that are in a more intense transmission rate. The next slide shows the descending order of the states. We see an important growth for Mexico City. Tabasco is ranking second. Yucatan and Baja California have similar numbers. If we are to take a look at this based on the population, is that we can compare the different federal entities. Next slide shows the distribution of fatalities. They are arranged by the date of death. We can see the different dates where we are still having high fatality numbers. Those bars in yellow are suspect fatalities. We're still waiting for laboratory test results, and they concentrate on the latter days of the curve based on the confirmations of laboratories. This is, again, the distribution by state. You can see the burden of fatalities per entity, and the orange color that's on top of each bar that accounts for suspect fatalities that are to be confirmed in the next days, and probably the number of deaths per entity will increase through the days. This is the epi curve that we update every day. We see still an upward trend. We see confirmed cases and suspect cases. Most of suspect cases, nearly 55% of them, focus on the two states with the heaviest transmissions, that is Mexico City and the state of Mexico. Here you can see confirmed cumulative burden of the disease. In the past 24 hours, we had 3,329 new cases. This is an increase of 5.3% versus yesterday. And you can see this has been the highest bar, where we have 65,856 confirmed cases. We had been expecting this. Apart from those entities that have been going through their peaks, we have now more numbers coming from those states whose curves are going up. We are expecting that every day we will have higher numbers than the day before. Now, this is the availability of beds and hospital occupancy, 97% notification rate. It's pretty good. Out of the 24,042 general beds, 9,206 were occupied by somebody who's presenting severe symptoms, and this accounts for 38% of bed occupancy. Yesterday, the figure was 39%, so it's pretty stable. Now, this is the national distribution of the 38%. It is an average obtained from the different states. On the right-hand side are those entities with fewer bed occupancy. And now, ranking first, we have Guerrero with 76% occupancy, followed by Mexico City. Bed occupancy has declined in Mexico City, and there's still availability for beds. Next slide shows ICU bed occupancy. Those beds for the people who unfortunately require a mechanical ventilator to have assistance assisted respiration, sorry. Figures are stable, 34% nationally. And we see Baja California, the state of Mexico, Mexico City. On top of this chart, percentages still give room for bed availability. This is the daily report for today. Thank you very much, Dr. Jose Luis Salomia, the director of the epidemiological unit. Let's open up for Q&A round. First you and then you. Hello, Juan Hernandez from Basta Newspaper, Grupo Canton. Something calls my attention from these graphs. Tabasco. What's happening in Tabasco? Not long ago, you remember what happened with the special curve you talked about. You talked about this on the 10th of May. The population disobeyed, and that led to a new outbreak. Do you think something similar can happen? Remember what happened in Wuhan. Do you think we could have our own Wuhan, Iztapalapa, Nezahualcóyotl, and the urban areas of Mexico City? Do you think something similar can happen around there? Because let's be honest, people are not observing the measures of safe distancing. People are behaving with rebelliousness. They are not obeying. I don't know if they don't want to understand. They just don't want to see the reality of things. It's not that we think that people don't want to understand or that they just don't care. Something we've been identifying, and this is something that we forecasted since we were preparing for this in January. The resilience of society towards restrictions in mobility this entails not being able to go to work. For example, people who live hand to mouth and they don't have a fixed wage, they need to find a way to make ends meet. If you have a plumber or if you have a mason, you have somebody in there selling goods from handicrafts or food, etc. You have people who own small stores of any category. Since they can't go to work, they're not serving their usual number of clients, then the economic struggles start, and they are really pressing. It's no minor issue. We're talking about winning the daily bread for the families and hence for the communities. Therefore, the more important the need for somebody is, the stronger the motivation to go out and look and find ways to win the daily bread. So let's remember the first days of February when in Europe people were going through the most intense phase of COVID-19. And part of some people in the public opinion in Mexico were spotting the urgent need to closing airports and closing socioeconomic activities in Mexico. And we kept saying, not yet, not yet. First, it was not a good time to do that because we had no single confirmed case yet. If we were to close flights, specifically those coming from Europe, we could prevent the introduction of the virus in Mexico. But if we remember the history of pandemics and the methodology of epidemiology and science, there is no formal way to stop an epidemic by closing all points of entry to a country, whether it's by sea or by land, by air. And this would be something hypothetical or like a state of siege, a military siege. This is a very far-fetched scenario, and this in turn makes things very complicated and almost impossible because that would lead to immediate scarcity of the basic needs of consumption or of survival for a society. And then on February, we had the first confirmed case, and people were pressing, you need to close, so on and so forth. And there's been some um, reflection upon the fact that a sector of the population focuses their fears, and sometimes fear is not necessarily productive when it comes to aiming for social solidarity. Sometimes some people say, why don't you use the public force? You need to imprison some people who disobey. And I'm not saying that everybody who expresses this come from the same place. Motivations might come from different places, but sometimes this is just a reflection of the standing of somebody who doesn't know that those who are outside have different needs, might have different needs. If you're wealthy enough, if you have savings, maybe you can afford not to go out on the street looking for money to win the bread for your family. Probably your situation is different and you can stay at home, but those who can't do that, and this is a huge amount of Mexican people who can't afford to stay at home, they need to go out and try to make a living. That's why we are considering that the gesture of solidarity and responsibility of those Mexicans, uh, they are being heroic because they've been at home in a very disciplined way, and they have contributed to a reduction in the pace of propagation of COVID cases, therefore of the virus. And that's why we have had a better control that right now is keeping our hospitals not saturated. So, or respect and acknowledgement to that people. It's been now 2 months and a few days since the implementation of the national safe distancing campaign. And locally, regionally, at some states, there's still a long way to go, and restrictions are going to remain, as we said before. So it is important to keep calm and to be clear that not always is possible to stay at home indefinitely unless circumstances would favor it. Sometimes you can't use the public force, or you must not use the public force, and that's some decision that we made since the very beginning. We opted to talk people into staying home. There's not good sound to get to his next question. Thank you very much for saying this, because next week, every day, we're going to talk about the stoplight, and our communication is going to focus on the fact that the 30th of May is the ending of the national safe distancing campaign, but by any means this means that we are going to go back to the normal as we knew it before the beginning of this national safe distancing campaign. This means that in some states we're going to have some restrictions in place, mobility restrictions. Some other states might start reopening some activities, and some other entities might have restrictions or reopenings in at a different stadium. So the red stoplight means that there's a higher risk of transmission because the epidemic curve is showing a climbing trend, or maybe there is a saturation, or we're getting closer to saturate hospitals, amongst other parameters. So when the stoplight is in red, only essential activities will be open. When we have an orange stoplight, non-essential activities will join up with restrictions. When we are in yellow, we could have a coexistence of essential activities and non-essential activities, using protection measures, having protection measures in place. Hygiene measures will remain for years. And once we reach the green color of the stoplight is when schools will reopen, not before. That's the structure of the stoplight. So we must try to identify this, and this is why things need to be done at the right time. If you take too long, what happens is what unfortunately has happened on many countries who had the beginning of the epidemic. And well, that is too sad because they were the first and they didn't have time to learn from others. And they lived very, very intense epidemics, 8 or 10 times higher than what we've been living in Mexico. The more the population, the more cases of fatalities. Countries with smaller populations have fewer fatalities. But if you compare this with the incidence rate, which is what we're using to compare the different states, we can identify all the different cases. So the crux of things is, if it is too early, we're going to exhaust the population with an early implementation of measures. If it is too late, then we're going to pay the price in terms of the consequences of the epidemic. And Mexico did this when we planned to do so, right at the moment when the pace of growth of the pandemic changes. We started up with the National Safe Distancing campaign, and then we will have uh, local campaigns. The case of Tabasco, as we explained the other day, there is a second epidemic curve, and technically this is called bimodal. There's two humps on the epidemic curve instead of just one. What this suggests is there was a change in the intensity of mobility. We started out with a reduced mobility, but maybe at some point, at the beginning, in the early days of May, people went out and contagion and confirmed cases went up. The good news for Tabasco is that they are far from getting the saturation point. They made a great work of hospital retrofitting. Tabasco was one of the first states who did that at a very early point in time. The governor and Silvia Roldan, the Minister of Health, a very dear friend of mine in the community, they both implemented and started working on the retrofitting scheme. The case of Tabasco, do you think is an indicator that Mexico City or the state of Mexico can show a similar situation? Any population, the moment mobility begins, have possibilities of having more contagion. The more mobility and the more people are there moving around the public space, the more infections will be. And let me repeat something that we've said before, and today, Saturday, the 23rd of May, please remember that I repeated this. It is no guarantee, neither in Mexico or anywhere else in the world, that the moment that we start reopening, it'll be guaranteed that no outbreak will happen. This needs to be very clear to you all, communicators, to you, members of society. The moment the reopening begins, we will have new outbreaks. This needs to be clear, but it is really inconvenient and potentially really harmful to think that we might continue with this immobility for way too long. Mexico needs to follow the lead of other countries. We need to start testing our mobility experiences in an orderly way, in a staggered and careful way, with a continuous monitoring in place, identifying very clearly to help the governments and society and tell what's going to be the level of risk, and activating the social, economic, and educational activities of society based on the magnitude of risk, doing this in a staggered way. And that's what we're going to do. The moment we still detecting changes in the behavior of the epidemic, we take measures, and then mobility will be reduced because it must be
Luego la
reduced.
compañera de
Perfect.
atrás, luego
You,
Fernanda,
then
Carlos.
the girl on the back, Fernanda, Carlos, and then Dulce.
Gracias, doctor. Daniela
Thank you,
Pastrana,
Doctor.
de Pie de
Daniela
Página.
Pastrana
Tengo
from
un
Pie de
par de preguntas.
Página.
Una es,
I have a
estos
couple questions. One, out
7.175
of these
fallecidos, ¿tiene un
7,175
porcentaje de
people who
cuántos
have
han
died,
tenido un
do you
cuadro
have an average
con una
how many of them
comorbilidad, con otra
are
enfermedad que
showing
haya
comorbidities?
detonado
Do you know what's the
pues ese
percentage of them
cuadro
that had
ocasionando su
other
muerte?
diseases
Si
that
tienen ese
probably
porcentaje, ¿cuál es? Y
led
luego, en
to
relación con lo que
complications
acaba de
causing
decir,
their
están
death?
diciendo que la
And based
OMS
on what you've just
declaró
said,
que
the
Sudamérica es el
WHO
nuevo
declared
epicentro y
South
que en regiones como
America to
Francia
be the
y
new
como,
epicenter of
bueno,
the
Francia
pandemic.
mandó a
France
limitar el acceso a las escuelas.
restricted
En Italia,
access to
pues está esta
schools
región de
again.
Lombardía donde
In
sigue
Italy, we
también
have
sin
the
la
region
pandemia.
of the
Entonces,
north where the
preguntarles
pandemic is
si es
still not
posible que
under
este
control.
semáforo se nos vaya de
Is it
puntos
possible
por
that
el
the
año, ¿no?
stoplight
Más o menos,
scheme
qué expectativa
might
debemos tener
take
del tiempo en el
over
que vamos a
the
estar
rest of the year? For how long
con
do
este
you
semáforo
think we're
permanente de
going to be
alerta y con
using the
posibilidades de volver
stoplight? And
a limitar, sobre todo esto de los espacios en escuelas y en espacios
thinking
como
about
bibliotecas.
restricting
Y
spaces like schools and
qué información
libraries
tienen
and
sobre
parks,
la
what
inmunidad.
information you've got
Vimos que había
about
ya algunos
immunity?
avances con
We
algunos
saw there was some progress.
changos, macacos, sobre, bueno, algunas
Some monkeys
investigaciones que
had been
podrían ya
tested,
hablar
and
de
there's been
que sí se
research
puede
going
pensar que va
on,
a haber
and
inmunidad
probably this
de quienes
might
tuvieron
lead
contagio.
us
Quería
to
saber
think
si
that there might
tienen alguna
be
información
immunity
más
for those people
específica.
Muchas
who
gracias por sus
already
preguntas
got
que,
sick. Thank you
que
very
son
much
muy
for your
útiles y muy
questions. I
importantes.
think they are very pertinent
Sobre las
and spot on.
comorbilidades.
But I'm going to
Semanalmente,
talk
esta
about the
semana no lo
comorbidities.
presentamos,
Every
pero
week,
queremos
we
traerlo
didn't
mañana.
present it this
Ponemos
week,
un
but we
siguiente,
can
cuál es
share
la
this tomorrow.
proporción o el
We
porcentaje de
can
personas
share the
que
ratio or the
entre el grupo de
percentage
los que
of
desafortunadamente
people
fallecieron tienen
amongst the group who unfortunately
hipertensión,
died. Who of
obesidad,
them had
diabetes,
hypertension,
tabaquismo
obesity,
y otras
diabetes,
condiciones de riesgo.
smoking,
Ha
well,
cambiado muy poco a
who
lo largo
and
de
other risk
estas
conditions?
semanas de la epidemia
Over the
en
past
México
weeks,
y
things
son
have
los
changed in
determinantes
Mexico,
principales o las
and those are the
características
main
principales
factors
que
or
se
the main
asocian con el riesgo
characteristics
de mortalidad.
that are associated to this risk of mortality.
También los hay
Yeah.
y esto me da pie a comentar lo siguiente.
We also have that, and I will tell you the
Ya lo hemos
following.
también dicho, pero quiero retomar.
We've said this
Y esto es
before, but
para la
I will
población. COVID,
mention it
COVID es
again.
una enfermedad,
This is
como
for the
puede haber
general
otras,
population.
pero es una enfermedad que
COVID-19
puede generar un
is an
fenómeno
illness, as
de
many others,
sorpresa.
that can create
Sorpresas en el
this
sentido de una
surprise
persona que se asume sana,
phenomenon.
que se
There's
asume
a surprise
razonablemente
factor.
joven
You
y que
might
por lo
think you're
tanto, al
healthy, you're
escuchar estos
young,
mensajes aquí
and
o en otros
when you're
sitios,
listening to what we're saying
tiene
here
claro que adultos
or
mayores de 60,
elsewhere,
mujeres
you know that
embarazadas y personas
the
con
elderly,
enfermedades crónicas
pregnant women,
deben
or people
acudir
with
a la
chronic
valoración médica
diseases
si presentaran
need
los
to
síntomas de COVID.
go see a
Fiebre,
doctor
tos, dolor
if
de
they
garganta,
were showing
dolor de cuerpo,
symptoms:
enrojecimiento de los ojos,
fever,
escurrimiento de
sore
la nariz,
throat,
etc.
eye redness,
Y
runny
quizá
nose, tight
asume
chest,
esta
etc.
persona,
But
estoy poniendo un ejemplo
probably a
hipotético, pero por si usted se
young and healthy
identifica
person might
en
think,
esta característica, tiene un
probably
familiar que
you
se
might
identifique con
relate,
esta
or you
característica,
might have
piensa que
a
es
family
demasiado
member
joven
who
o piensa
is
que es completamente
similar to the
sano
person I'm
o sana.
describing. They might think,
Y
I'm
entonces si
completely
tiene
young, I
síntomas de
am
COVID,
completely healthy.
se
So
espera
if they have
y no va
COVID
a
symptoms,
consulta,
they
y se
might
espera y
not
no va a
go to see a
consulta, y se
doctor,
espera y piensa
and
que se va
they're
a
just
recuperar
waiting
en
and
algún
thinking
momento
that they
pronto.
might
Pero
make it
quizá
and that they
empieza a
are going
tener
to
algunos
recover soon. But
síntomas que
probably
aquí hemos mencionado y que hoy voy a
they
volver a
will
mencionar.
start
Y usted no
exhibiting
está haciendo
symptoms
suficiente caso.
that I'm just going to
Estos síntomas
mention,
son los
but you
síntomas
just
tempranos de
pay
la
no attention.
complicación
These
de
are
COVID
early symptoms
y
to
que se
COVID
presentan precisamente
complications,
por el daño pulmonar
and
agudo
they
grave que
start
esta enfermedad puede
showing up
producir
because of the
en hasta
severe
2 de cada 10
failure or the
personas
severe damage, sorry,
enfermas.
that
Y los
it can
síntomas
cause
son
to the lungs of
disminución de
people.
la capacidad
Symptoms
respiratoria
are
que
a
se manifiesta
reduction
por
of your
la
breathing
necesidad
capacity,
de
you need to breathe more intensively and heavily because you feel that you are not inhaling enough air, or probably you climb up the stairs or you work out mildly, you walk and you feel that you need to breathe more rapidly, or probably you feel palpitations, or maybe you look pale, or maybe you still feel drowsy or sleepy. These are symptoms of COVID complication. If this happens, means that you've waited for too long and it is urgent that you go to a healthcare unit, because if you're still waiting, the ending for you might be fatal. So this is of utmost importance, because what we have seen is that, unfortunately, and tomorrow we're going to show the figures, there's people who didn't know they were ill. And in Mexico, we have a very high risk of diabetes. We've explained it's people that been undergoing a bad nutritional regime for 40 years. And there's people who didn't know they had diabetes until they got tested for COVID. In Mexico, out of 14% of the population who is under 20 and who have diabetes, 14% of the population, half of them, didn't know they were diabetic, and they discovered it when the National Survey on Health and Nutrition was on, and then they got a lab test and they detected high glucose level in blood. So what do we recommend? To be always suspicious, sorry, if the person is overweight, if they have relatives with diabetes or hypertension, that's one more reason. And you shouldn't wait, and please go see a doctor.
There are other symptoms that the healthcare personnel could detect in order to see any complication in regards to COVID, confirming the case of disease by using lab testing, and also monitoring oxygen presence in blood with special devices called pulse oximeters. That is something we widely recommend. And about the other two questions, about immunity, I would say that we've got hope. There's hope, but the scientific evidence is not as consistent. We have hope because we have the experience from other coronavirus, including SARS from 2002 and 2011, other four coronavirus of common circulation in the population. There's hope to have an immune response that would then give protection in terms of biology for this infection, but we still need evidence around the world in order to confirm that. There was another third question. What can we expect from the time? Well, this is important. We still need more events and episodes to identify throughout the epidemic in Mexico and around the world. And it is difficult to have a general forecast in terms of how long this SARS-CoV virus is going to circulate and bring about disease. Virus SARS-CoV-2 is going to stay forever, or if not forever, it is going to be here for many years. And we know that because many other coronaviruses circulating. And as long as we establish an ecological balance with the human population, this would depend upon immunity in a great deal. That's when we will have a condition where, in spite of the virus frequently being throughout the population with no environmental reservoirs known, that we are still studying, and we've talked about the bats and other animals and species of wildlife that could then become reservoirs, but this should be kept in silent chains of transmission, and also in wildlife. It is difficult to predict for how long this is going to create disease, but an important element is that the percentage of the population developing immunity in the case that immunity is actually giving protection against infection. We have some preliminary results according to some serological surveys around the world. I'm mentioning the one in Spain when we identified 11%. It was a surprise to find that in Madrid, the most populated and most impacted area, it's only showing 5%. In the county of LA, we had a survey published with 4.7%, the percentage of people with the antibodies against the virus SARS-CoV-2. In New York, there were some results published with 23%, and that's how the ratios are going to be known. But as we commented last Saturday, the herd immunity would be the amount or ratio of people that within a society would require immunity for them to stop transmission, and this would require to be.
Una pregunta que quizá resultará consecuente es, ¿y México cuándo va a hacer su encuesta de cero prevalencia?
We have an issue with the audio. 65 to 70%, so we still need more. Another consequential question would be, when are we going to have our zero prevalence survey? We've already said that our survey is going to have a specific component for COVID, and we are thinking that by July or by August, we'll get started with the collection data and blood samples. And I thank you for this question, Andrea. What does it mean when we say that we need to get prepared for a long epidemic? That's something we said even before the first case. We needed to get prepared for a long epidemic. The curves in different cities and different states throughout the country are going to be exhibited through July, June, even August. Maybe some of them will go all the way to September. Some cities like Mexico City, in comparison, would not have a high transmission. And since these are large populations, the epidemic is going to last, and it is going to be projected until September or October. And in October, then we have influenza season getting started. It is not guaranteed, but it is possible that with the influenza, we could also have a rebound of COVID, and the challenge is important because once again, the hospital occupancy could be combined with people infected with severe acute respiratory infection and the COVID cases on the other hand. That's why we need to be prepared for a long epidemic season. Let's go to the next question at the bottom, then Carlos, Fernanda, and Dulce, please, and then you as well. Hello, doctor. Good evening. I am Paola Betancourt from Multimedios, and we are constantly informed about the flights bringing inputs. But this week, we still have medical personnel from hospitals in Texcoco and Venados Hospital. They are protesting. Why are they protesting still? Why are they demanding the PPE as they require in order to fight back this pandemic? This is a very frequent question. It is very important to know that those protesters are in their full right. That is very important to say, and it is very useful whenever concrete information is also given. Our information is that this has been distributed in the system. Venados pertains to the hospitals of the Social Security, and this should be common in terms of patients estimated to to be taken care of, and the size of the infrastructure and the number of people of the medical care staff in general. So I do not know precisely what the reason of the protest is. You've said that the motivation is because they have identified that they don't have the proper amount of equipment, but it is important, of course, to identify where the supply chain got stuck. I can guarantee that the planes, the inputs come at the central level of the Social Security. To give you an example, the inputs are managed. They're sent to the representation offices in every state that we call delegations in the past, and that's how they reach the different sites. And locally, dynamics would change, and probably that's where the problem is. We have Fernando, Carlos, Dulce, and the two of you, please. Good evening, Fernanda for glucosa atómica. Two questions, doctor, please. First, we would like to know your opinion about Lancet articles, multinational studies about hydroxychloroquine with macrolide or without it. They concluded there is no therapeutical benefit whatsoever, and it was associated to ventricular functioning. And another vaccine that was also tested in Wuhan, China, that is quite promising against SARS-CoV-2. Another question, some days ago, we had the specialists dealing with the teenagers and children, and in the media, I was asked what support was given to those children who are now orphans due to SARS-CoV-2, and how are you working with this topic? The first question, okay? The answer, the immediate answer would be that this is a tragedy. This is very unfortunate. This happens with many other diseases that are prevalent in Mexico or that bring about death. Even the external causes that would be the general cause of death, like violence, hypertension, diabetes, that are the top reasons. And this is not specific for COVID-19. Whenever someone becomes orphan at a very young age, and we have different mechanisms that would not necessarily be the only ones or responsibility, exclusive responsibility of the federal government. We have municipal and state mechanisms. The Institute of Family Development, DIF in its Spanish acronym, at times what they do is that they articulate efforts in what they call the social assistance that is part of the responsibility of this institution, looking for mechanisms with funding, with institutional support, whenever we don't have any relatives that would then take charge of children, then we need to have institutional coordination to receive them, the hydroxychloroquine and the vaccines. This was published by this magazine you are mentioning, phase 1, the most preliminary clinical trial. 108 people were surveyed in a selected manner, not of highest risk category, and this is part of the clinical research protocol in order to assess security. Security is element number 1 to assess for a candidate, for a vaccine or any kind of drug. I would say that we have good results, but we are still missing the next research phases, replicating results from other groups that are within the research, independent from the first one, the opportunity that this would be replicating possibly in other countries, in other populations with different characteristics. So in a nutshell, this is, of course, giving us good spirits, but we still need the rest of the research. Dulce, Carlos, and the two of you, please. Hi, Dr. Alomia. I am from Aba Noticias. I have 3 quick questions. The first one is that before reaching this venue. We have the case of Guerrero. As it was noted on the chart, we have an important rebound in terms of increase. We were checking data. In the case of Chilpancingo, it's important, and Acapulco, because the major is saying that from the cases, 500 are in Acapulco alone, and she is mentioning a collapse of the system in this case. Please, could you clarify this? And second, you told us that every Saturday the municipalities list was going to be updated. And the third question, revisiting the sports topic, we know that the tournaments have been canceled in Mexico, but it could be then revisited later. Have you discussed this with the league leaders? Maybe with empty stadiums, we can have them now. Let me take this question about MX for me and the rest for Mr. Alomia. Well, unilaterally, this I would estimate that this entails great responsibility for those who are involved in the league, the directives, the people involved made this decision. This is good to diminish the epidemic risk at a national, regional level, wherever we might think that the matches could take place. And of course, for the personnel themselves, the players, the supporters, and everyone. When can we reactivate this? This decision is not made in regards to the league or the phenomena, the sector, the productive sector. If we have an analogy, that is the sports sector, this depends upon the color code based on the traffic light. So wherever we have a code in yellow or orange, then these activities might be taking place. If they have a red light, these activities should not take place. And this is positive, as appraised by me, that the League of Mexico was very proactive when they approached the government. We've been having a very fluent dialogue with the Ricardo Cortés promoting health. And also supervised by me and the secretary himself, then we can plan it. And whenever we find the best combination, so from the entrepreneur's standpoint responsible for this, they can then think the proper time to open up due to the restrictions imposed by the protection against the epidemics. They will be able to do so. And now we're going to talk about Guerrero with Mr. Alomia, and he's got precise information about the epi curves. In the case of Guerrero, specifically Acapulco City, this location has been behaving according to our estimations that precisely during these days, they will be reaching the greatest amount of cases. And mid last week, we estimated the highest load of confirmed cases, that is to say, people exhibiting the disease, and on May the 30th, and whenever we finish the new week starting tomorrow, we are going to have the highest burden of people in the ICUs. So we have an important increase in the burden of disease for those who are sick and in hospitals, but it is within our projections, in our curves expression. So if it is in our projections, it is according to our program and our preparation for healthcare assistance. So we are working directly with the authorities. So as we also had our interventions in turn in Mexico City, in Tijuana City or Culiacan City, we will also conduct these interventions mainly in this next upcoming week, when we will have the highest amount of cases. So we will have the proper attention with available beds for general hospital patients and COVID patients. We are going to monitor this very closely in order to update our projection. Our next week is an important week for Guerrero in general, because according to the projection, it is going to be the week where we have projected the highest burden of disease. Another element that I would like to tell you now that we are talking about Guerrero, but it's also happening in other states. In terms of these projections, we know exactly when the challenges are going to get started for handling locally the epidemic, and we've assigned some executives that are coordinating the links between the federal government and the local government, along with the ordinary mechanisms by the institution. In the case of Guerrero, we have Rocio Bárcenas from the Family Development Institution that is very proactive with good experience, and she's been sharing information. We do the same, and that's how we have this very close mechanism bond. And it is good that you are asking, because originally every Saturday we said we were going to present and exhibit the municipalities list. We gave the first presentation and we listened very respectfully the reaction, the response from the governments pertaining to the states, and we know that many of them, and it is not that they have expressed that publicly, but throughout the week we've had several meetings. On Tuesday we're going to have one with CONAGO, and they expressed several concerns about the municipalities of hope, and they made their own decisions, which we respect in full. We must remember that the governors are sanitary authorities, and they made the decision that these municipalities could not be taken as low risk because of direct knowledge of the social dynamics in these states and municipalities correspondingly. So we wouldn't like to show a list that would then confuse, because those residents might be hearing that information and maybe they would interpret it as if the governors, both male and female, are doing something opposite to the federal government. So in order to avoid that confusion, for the time being, we are not going to display this information with that periodicity. Now it is 7:52. Olinka Valdez from Eje Central. Doctora Lomia, you said on May 22nd there were 50,000 tests to inmates. And I'd like to know if this has been conducted on a daily basis and how many inmates are now sick with COVID. And you published a protocol for caring for this type of individuals, recommending to have isolation areas for those inmates presenting and exhibiting symptoms. Are you applying these tests in this type of facilities? And I'd like to know how much these 300,000 tests cost and how they were distributed per state. Yes, indeed, activity is still ongoing. If you want, we may update data tomorrow. The Institute is now supporting Mexico directly for this intervention. The Institute of Epidemiological Diagnosis and Reference Institute for those inmates and the newcomers are now conducting this special protocol. It is not the epidemiological surveillance that we have in Mexico focused on suspicious cases. These persons would not exhibit any symptoms, but we are looking for a classification or a status of carriers before going to an area where they could spread the risk of transmission as such. So on a daily basis, practically, we are getting samples from this protocol. In some cases would be 30 samples, in other 40. We will update the figures. Obviously, these are figures that are handled and are more clear for Mexico City, because this is an intervention that was designed by Mexico City in terms of application mainly, but it would be our pleasure to ask for this information to the Diagnosis and Reference Institute. There is a guideline that was published some weeks ago, precisely thinking that we could have a very important risk in those people under certain conditions, and that for that, those people in charge should then conduct prevention actions pretty focused. And there are many actions that we could even find in the guideline of confined spaces, for instance, but due to the specification of the dynamics conducted in this type of facilities, we opted to have a specific guideline as well. This guideline is widespread, like many other guidelines in terms of the application. We have the direct responsible parties in every area, and for implementation purposes, and depending upon the location of that facility, we have a link with the state for inputs, for epidemiological surveillance, for the promotion of health individually. So it is an implementation that is constant. This activity that was defined by Mexico City, and for that reason, Mexico is over control. This has been defined precisely for Mexico City. It is not something included in the guideline as such. This is based on the risks where we could have some state or some facility specifically speaking. Could you tell us about the tests that have been conducted in these environments? Yes, we will update that information for you tomorrow. Yes, from the 300,000 tests, and just by reminding the report yesterday, we had 100,000 whenever we got this other additional 300,000. These 300,000 as such, and taking into account the 100,000 that are just about to run out, we will be using these 300,000 for June and July in order to follow up on the epidemic. These 300,000 have not been allotted in full throughout states, and it is not the procedure either. It is not that we are getting the tests and that we would then send them immediately and divide them. No, we have a control. The Epidemiological Diagnosis and Reference Institute would keep custody over them, and they would be using in the states, and the control is daily with a platform where the states are now recording the daily usage of their inputs, and according to this monitoring and the needs of the states, then we have shippings according to the groups for tests. We need to keep them in custody. They should be kept in cold weather with surveillance of quality over them, and based on the capacity of each lab, of every state lab, we have different sizes for each one of them. And if they don't have any excess and not going beyond their storage capacity, or because the reprocessing of tests is less, then we have an estimate according to these factors, according to several indicators, in order to define periodicity and tests to be shipped. But the entities already know that if in a certain point they require an extra additional amount of tests, the state head of the lab would then call upon the Epidemiological Diagnosis and Reference Institute to get in 48 hours the test. We are not going to focus in that question. We still have half a minute for another question, different topic. From Verificado reporter, it's been mentioned for many times the bad nutrition as one of the highest factors of risk, but it has been published for both COVID and influenza, the presence of pollution, environmental pollution, as one of the triggers for severe cases. Have you thought about reinforcing through legislation or a campaign that the most populated cities in our country would report unacceptable levels of environmental pollution? Yes, that's a very good point. I don't know if we have robust, specific information for COVID and the influence that the pollution would have, but it is for periodic diseases, influenza and other respiratory diseases. We know that pollution is working against health. Another phenomena is altitude, that we cannot modify it. We conducted a research with Dr. Perez Padilla about the risk of complications with altitude, and there is association in that sense. It would be quite desirable. I don't consider that only the existence of a pandemic like COVID would be the only boost to get better air quality, but I can tell you, because I have the privilege of working with the megalopolis committee, that we've gone through this topic with much interest, identifying many delays that are very important in our public policy regarding the environmental pollution and many other topics involved, but particularly with quality air. And Victor Manuel Toledo, our Secretary of and the Environment, I know, and I'm very clear that he has a very intensive agenda in order to improve the quality air, among other qualities. So right now it's 8:01, and we'll continue tomorrow with outstanding topics. We'll get started with you. Thank you very much.